Good morning, everybody. Welcome to the Myasthenia Gravis Association webinar on vaccines and myasthenia gravis. We are so thrilled that you're here today. If you're new to the Myasthenia Gravis Association, welcome. We hope that you find this presentation helpful and will continue to join us either in person or virtually for programming in the months to come. I first want to give a shout out to a new face that we have on this morning. I want to introduce everybody to Catherine Clemens. Catherine is our new community program coordinator based in St. Louis. So,
good morning.
Hello to Catherine. And then also, probably a familiar face to most of you by now, McKenna Fulton is our community program coordinator in Kansas City. Yesterday was her 1-year anniversary with us. So McKenna, thanks for all the work you do and being on this morning. A couple quick announcements before we turn this over to Dr. Pasnoor. We have several great webinars coming up in February. One where we'll be joined with Maya, who is an artist and a pharmacist who has myasthenia gravis living in Italy. That is on Saturday, February the 24th. Grab a cup of coffee. It's a little early at 9 a.m. Central Standard Time because Maya is in Italy. So you'll get a link in the email following today's presentation if you want to sign up. Our virtual monthly meetup in February, we're going to rehash everything about clinical trials and the process. Our friends at Immunotherapy are going to help put on that presentation. So that is Monday, February 26th from 6:30 to 7:30 p.m. Central Standard Time. Also, you'll get a link following today's meeting if you want to sign up. So we have the chat open and the Q&A open for questions. I'm going to let Dr. Pasnoor take it away and fill us in on vaccines and myasthenia gravis. We're so appreciative of her time this morning and all the work that she's doing in the myasthenia gravis community and at the University of Kansas to help all of us. So Dr. Pasnoor, we'll let you take it away.
Thank you, Allison, and welcome, Catherine, and thank you, Allison, for that introduction, and thank you all for being on this, and welcome this morning. Good morning, and let me share my screen, if that's okay with everyone here, and make sure that it works, and we looked at it earlier. So just making sure that you can see the screen there. Yeah, so today I'm going to be talking about vaccination and myasthenia gravis. As you all know, I'm from Kansas University. I'm a professor at University of Kansas, mainly focus on neuromuscular disorders, and myasthenia gravis is my area of interest, and that's why I'm here. And I'm also on the board and advisory member for the MGA support group. And so thank you for giving this opportunity, Allison and the group here. So just these are my disclosures, and I won't be using any of that in my talk today. However, these I've been serving as a consultant or medical advisor for some of the companies, which are mainly my areas of interest. And so going on to questions about vaccination and myasthenia gravis. These are the questions that come to mind for all of you when you're thinking of vaccinations and myasthenia gravis. Are these vaccinations safe for MG patients, for me? And do the vaccinations cause myasthenia exacerbations? Do vaccination cause new onset MG? Like, did it cause me to have the MG? And how effective are these vaccinations if I'm on immunosuppressive therapies in MG and have MG? So these are the questions that always come to our mind. So through my presentation, I'm going to talk about and show you some literature review and some prior studies and everything that have shown whether these are, for an MG, again, there's not a huge literature, I would say, but I'm going to present some of the literature that we have here. So vaccinations, so they reduce So what are what do vaccinations do for a body? So they reduce risk of getting disease by working with your body's own natural defenses. That's the mechanism that it works. As you know, like in 1796, when Edward Jenner first started looking at smallpox and trying to develop a vaccination, since then we have come a long way. We have many vaccinations that prevent some of the very serious infectious diseases, like they prevent approximately 5 million deaths every year from diseases such as diphtheria, tetanus, pertussis, influenza, and measles. And since the vaccinations have come on, there's been decline in many of the lethal conditions, over the years. And eradication of smallpox is also because of the development of these vaccinations. And if you look at this picture here, I mean, this is the mechanism. Basically, you inject a person with weak or dead bacteria or a part of the bacteria. And then what we are trying to see is our body develops these immune, like the white blood cells, they get activated when you give this, these products. And they produce antibodies that fight these diseases. And when the disease, like when the infectious agent comes into your body the next time, they basically attack those and help prevent it from invading your cells. And so that's how they work. And we all are aware of that. And there is various newer vaccinations. I thought it was an interesting, just a cartoon from Children's Hospital of Philadelphia, like their website. They had vaccination education, just showing you the types of vaccination. There are vaccinations that are made by weakening the viruses. They are live attenuated, is what we talk about that. And then there is the inactivated virus. You basically inactivate them and give that. And then there are vaccinations that give part of the pathogen, that give you part of that infectious agent. And the other is inactivating the toxins that they produce and then giving that to which produces an immune response in your body. And then there is all these newer vaccinations that you all heard of during the COVID, and even prior to that, they were started the mRNA vaccine, the DNA vaccine, and the vector virus vaccine, where they inject the vector, like a virus is used to inject genetic part of the virus. And so basically there is different virus and different vaccinations. So why do we need different types of vaccinations, and what are the advantages and disadvantages of having one over the other? And this is a nice table that's summarized in Frontiers of Immunology by Kyung Zhou et al. They basically talked about, like, what are the advantage of having a live attenuated vaccine versus mRNA vaccine versus, and what are the disadvantages of one over the other. Like, if you have a live vaccination, it may retain most of the pathogen immunogenicity. That is, it lasts longer, the effect lasts longer, and so you may not need more boosters, or so immune response is long lasting protection. Whereas again, but the disadvantages are that it can be virulent, and it's you're giving a live vaccination, especially if someone is immunocompromised. Like if you're on immunosuppressive medications, you may not be able to give this. And so there is, again, the killed vaccine, no virulence, reversal easy, and preservation is easy. Again, preparation is very difficult, and how to carry that is difficult for live attenuated vaccinations. So you can see there are differences, there are advantages of one over the other, and there are disadvantages of the one over the other. And just going, again, I'm not going to go through each of them, but most of these, again, you can see the easy way to carry them or preserve them. Some of them are easier to preserve, some of them have less virulence, some of them, like if you look at the mRNA vaccine, those are the vaccines that have been more during the COVID. You all heard of this. It is safe and rapid development and production. More protein is produced, and compared to the naked DNA, it's controllable, and it's transient. Usually the effect is transient. It's easy degradation, requires cold chain transportation. So that's the disadvantage, and that was one of the reasons why it could not be given in some of the countries, because of the easy degradation and requiring a cold storage for that. So you can see that there are some advantages and disadvantages of each of these vaccinations. Again, some of them, I mean, people worry about like, can it cause changes in my genetic constitution? And, like there is some potential risk with some of the vaccinations, like the Ebola vaccination, there's chromosomal integration with that. So there are some vaccinations that I understand that there is, some risk of that, but the mRNA vaccines, they're easily degradable and they're transient. So you can see there's advantages and disadvantages of some of these types of vaccination. So when you think of vaccine, these are some of the things that come into mind, like the delay. Why is there delay in people accepting or trying to? Why are they? Why do they refuse? So there was some surveys done. I'm just putting one survey from Sydney in Australia, but there are other many surveys have been done during the COVID time to see why people have a hesitancy to get the vaccination. So what is vaccination hesitancy? It is the delay in accepting or refusing of vaccines, despite like there is availability of vaccine services. So what are the causes? What people are scared of or you are nervous about? So one is safety. Is some people feel like, are these ingredients in the vaccination safe for me? And some people have like confidence. Some do not think that this vaccination works. And risk perception, that is, some people feel like do not think that they are at risk to get this disease, so why should I take that? These are some of the things. And then distrust, like, do you trust the healthcare system? Some people do not trust that this was developed in the right way, or and so there is various reasons why people have a hesitancy of getting vaccinations. So reason for vaccination hesitancy, this survey shows that, like some people said, I'm nervous about the side effects for my age group. I do not know about enough about these vaccinations. About 38% said that. This was during COVID. And some said, like, I want to wait until more people have been vaccinated. Some said, like, I'm not traveling international, why should I get it? And some said, like, the risk of catching COVID for me is very low because I'm not exposed to as much. Again, there was a small percentage of people, again, saying, I'm too busy right now, I do not have regular GP, I'm opposed to all vaccinations. Is a small percentage of patients there. So, you can see there's various reasons people have hesitancy on, for getting vaccinations. And it is individual choice, I understand. But, these are, so I'll be just presenting some of the data on vaccines and in myasthenia gravis. And some of the data here, this was one of the study by Sangani et al., which was published in 2018. So you see, this is 2018, so before the COVID era, and looking at, so they looked at the CDC FDA vaccine adverse event reporting system. You might have, I mean, some of you who have like, done the COVID vaccination, you probably got a message from like CDC asking you to like putting in, if you have any side effects. And some people have entered the information on like, well, after the vaccination, did they have any side effect or did they have any adverse event? And this information was collected from 1990 to 2017 in this study. And so this was before the COVID era. And total incident, so what they saw was total incident post-vaccination MG, that is, new onset MG, people who did not have MG and now developed MG, was about 42 definite cases. This happened within 6 weeks of the vaccination, is what they reported. This is all the patients reporting, and this is they entering the information into this database. And so mostly these were induced by influenza or hepatitis B vaccination. And if you calculate the incidence rate based on the number of people reporting this 42, it came out to be about 2.1 per year, which is like 2.1 cases that were reported with myasthenia gravis per year. So, which is actually the range that we expect in general population also. It's a rare disease, but that's approximately how much we see in general population also. However, because these were reported within 6 weeks of vaccination, is there a reason to believe that, the vaccination could have caused some of this triggering of this, development of this MG? Again, we don't know that answer, but there were a small percentage of patients also presented with the crisis in this, and these findings, again, they said because it's a need some continuous and careful analysis and monitoring for MG after vaccination, was what they said. This was from 2018. And what do we have in 2022? This is another study by British, and they looked at cases like they looked at new onset MG in 7 patients who got vaccination. Within 4 weeks of the vaccination, they developed like MG onset. This is like patients who did not have MG and developed MG. And so we are trying to see, is that because of the vaccination? Is it not because of the vaccination? We don't know. But basically, it happened within 4 weeks of vaccination. So they said because it happened within 4 weeks of vaccination, you can see the range of patients was anywhere from 13 years to 77 years of age. Actually, one patient was even 83 years of age, as you can see. And this was mainly during the COVID vaccination. And you can see that this was all COVID vaccination. And there were different COVID vaccination. There were Pfizer, AstraZeneca, and some of them developed after the first dose. Some of them developed after the second or third dose. And this was MG subtype was mainly a generalized or ocular. And they said possible. I mean, based on this, they concluded that there is possible temporal association between SARS-CoV vaccination and maybe onset of myasthenia in a small proportion of patients. Again, this was a small number of patients if you think of all the number of patients that had got the vaccination. And going on to another recent review from 2022. So this was a very comprehensive review. So basically what they did was they looked at all the studies that have been done over the last few years, and and they looked at any study on vaccination and myasthenia gravis done. And this was a large study looking at are vaccines safe in myasthenia gravis, and are there any risks of myasthenia onset or exacerbation after vaccination, or are these vaccines effective in patients with or without immunosuppressive therapies? People who have MG and are on immunosuppressive therapies, are they effective? So let's see what they came up with. So they had a large, like I said, this is a large study. They looked at like 138 articles, about 29 articles were relevant. They looked at, most of those, if you see, like 16 of them were case series. That is the people reporting that having like 3 or 4 cases or 1 case report. So there was a large number which were mainly case reports, but there were 11 observational descriptive case control studies. So there were larger studies. So I'm not going to go through each study, but I'm just going to highlight a few things here. And this was, most of these, you can see, I mean, they looked at influenza and MG, like people getting influenza vaccination and MG, people getting pneumococcal vaccination and MG, what happened to the MG, and or even in normal people, did they develop MG? These were all the various things that they were looking at in this group. So influenza, tetanus, diphtheria, and then the encephalitis vaccine, Japanese encephalitis vaccine, and BCG vaccine, which is given for TB in some countries. So they looked at all of these with MG, like in MG patients, and also compared to normal, people who did not have MG. So some studies had only looked at people with MG. Some studies looked at MG, CIDP, like GBS, like other autoimmune conditions. So this was one of the, if you look at some of these studies, they said like the first one was influenza vaccination was recommended by 80% of, neurologists who were surveyed based on, the experience and, a history of, the people who did not think that they would recommend was like if they had a history of exacerbation following influenza vaccine was the most important factor influencing the vaccine recommendation. And the other studies, as you look at all of these studies here, This one looked at 500 patients who were hospitalized with MG. There was no significant increase of risk of hospitalization or exacerbation after the influenza vaccination in these patients. And the mild exacerbations were mostly not included, but it was mostly they were looking at people who were hospitalized. And then again, this one, no exacerbations were seen in H1N1 vaccination group patients, and compared also to, influenza vaccination, they didn't see any exacerbations. And this study, which was interesting, I thought, they looked at 258 patients with 133 vaccinated versus 121 who had influenza-like illness or common cold. This was a retrospective study, like they went back and looked at these patients, and the number of patients who had influenza-like illness, that is like influenza, like common cold, or influenza-like symptoms, like cold symptoms or flu-like symptoms, these patients had more exacerbations than the people who actually were vaccinated with the influenza vaccination. And then there were other studies which again showed no clinical exacerbations, no significant difference in, I mean, this study also looked at whether there was increase in the acetylcholine receptor antibody titer after giving, the vaccination. And they didn't see and they didn't see a difference between that versus placebo control, the placebo group. They didn't see that. Onset of laryngeal, this one had, they saw an onset of laryngeal MG in patients with 5 after trivalent inactivated influenza vaccination. So they some showed that they developed, this was like one non-myasthenic subject, and after 6 months of that, they reported having a MG onset. So there are a few that showed MG onset, whereas most of them did not show any exacerbations. And like we saw, one study showed that more patients had with the infection, they had more more MG exacerbations than without the vaccine, with not without the vaccination. So now looking at Japanese encephalitis vaccination, this is a retrospective study. They looked at MG cases, like about 4,000 MG cases, and they also looked at prospective 104, like childhood onset MG patients. And with this, it was interesting that they did notice like increase of, this is, again, you have to remember, this is a live attenuated vaccine, and there was increase of anti-acetylcholine antibodies in both children and mice injected with this vaccine. And they had decreased muscle strength, response to repetitive nerve stimulation. That's the test we do for myasthenia gravis. They did see some abnormalities in that test also. So you can see that this one, they did shows there's some worsening of MG or new onset MG after this vaccination. And then BCG vaccination, again, this one, it was interesting with BCG. That's again tuberculosis. This is done in some countries, and this one, they did not see any exacerbations in people who got the vaccination for, to prevent the disease, but they also use this for bladder cancer patients. And they noticed that in this group of patients, they had some worsening, complete resolution, but they had some ocular MG after they gave them through the bladder. And however, they had complete remission after 12 days of steroid therapy, even in that group. So based on all this data, and I didn't put in all the other vaccinations, which was pneumococcal, meningitis, and other vaccinations. And they, based on this, they showed that influenza vaccination does not increase the risk of myasthenia exacerbation. Mild adverse effects unrelated to MG are possible, and influenza-like illness have higher potential risk. And then tetanus, pneumococcal, and meningitis vaccinations only cause minor reactions and do not cause any exacerbations. Live attenuated vaccinations in immunosuppressed patients, that is, if you're on immune medications, like most of MG patients are, usually, generally, they're contraindicated before you start the treatment, but you can do it before you start the treatment, but they're contraindicated when you're on the medications. That is live attenuated vaccines, and we know that. And that was safety. Looking at safety, what is what is looking at efficacy? Like, are these effective in patients with myasthenia gravis? Are these vaccinations effective? And these were various studies that they looked at in influenza, in tetanus, with the influenza vaccination, with tetanus vaccination, with diphtheria vaccination. Again, I'm not going to go through each of these, but they did see, there's less risk of, exacerbation in older patients. However, the vaccination does not confer protection from, some of them showed that it does not confer protection from, influenza-like illness, difference between this. But however, most of the studies did show that post-vaccination seroprotection was similar between healthy controls and patients with MG. So, most of these studies, as you can see, have shown that there is some benefit even in patients who have been on immunosuppressive therapies. And so the similar data was shown in pneumonia vaccination with the COVID vaccination. So the final conclusions from this, what they said was neither clinical nor serological differences. What do you mean by serological? That is the acetylcholine receptor antibodies, differences in efficacy have been reported between, so there's been no differences in efficacy, like between myasthenia patients and patients who, and other people who do not have myasthenia gravis. Between these two groups, there's no difference in there's in the serological or in clinical symptoms with these vaccinations. So neither immunosuppressive therapy nor thymectomy have a negative impact on the vaccine efficacy. So the vaccines are effective even in this in patients with myasthenia gravis, even if you're on immunosuppressive therapies. However, we'll talk about when to give the vaccination to make it to say that it will be effective. So in conclusion, from this, with these two, they said inactivated and subunit vaccines are safe in myasthenic patients. Vaccine should be recommended and administered to myasthenic patients. Increasing vaccination rates against respiratory pathogens might reduce the burden of disease exacerbation at the population level. Because we saw that, people who have the respiratory infections actually had more exacerbations than people who actually got the vaccinations. So that's why we are saying that, it might be useful. So now, what about new onset MG after vaccination? In the same study, they saw that hepatitis B vaccination, there were 4 cases that developed new onset MG. That is, after the vaccination, they developed, MG. In the BCG vaccination, there was 2 cases that reported having new onset MG. In the HPV, human papilloma virus vaccine, there was 1. And in COVID, they had like 4 cases that they reported in this group. And in this study, they looked at all their patients with COVID, in all the patients admitted and who got the COVID vaccination. There were like 80 patients, and out of that, like 4 cases had new onset. They had MG. So live attenuated Japanese encephalitis vaccination has a potential risk factor for childhood onset MG in countries where such vaccination is routine. So this is a vaccination with MG. There's a potential for that and needs more studies. So cases of new onset post vaccination are mostly anecdotal because we are seeing it's very few, except for Japanese encephalitis virus vaccination, which we need more information that has shown more, more factors like potential risk for MG. As far as SARS-CoV, like the COVID vaccination in this group, they had 4 out of 80 patients with MG. Patients experienced an exacerbation within 6 weeks of onset of this, and there was 1 case of new onset of post-vaccine. And then in conclusion, what they said based on their observations, rarely they can lead to MG worsening. MG and COVID-19 might trigger the exacerbation of either of them. But overall, they have noticed that the benefits of SARS-CoV vaccination in myasthenic patients still outweighs the potential risks of, not taking it. So this is another study I wanted to show. This was again published recently in 2023, and where they looked at, this was observational study looking at COVID infection versus COVID vaccination, and how many patients had exacerbation and how many patients had new onset MG. Like when we talk about new onset, I'm talking about like they developed MG when they didn't have MG previously. So if you look at people with COVID infection, there were 36 patients who had exacerbation, 35 in this group and 28 in this group out of the total there. You can see that. So there is, I mean, just with COVID infection, you can have, you can see MG exacerbation. So finally, like Dr. Mubiti et al., when they published they said like patients with MG have a higher mortality and morbidity than general population with COVID infections. So if you get COVID infection, there's more people with myasthenia have more worse symptoms is what they noticed. And similarly, even in the other study, they said like, patients with COVID infections have worse outcome there. And MG class 4 is associated with severe COVID-19 infection was also reported in this five patients had a death and 28 patients with MG exacerbation during the COVID time. That was in 2021. And then looking at vaccination, if you look at the vaccination studies, observational studies, out of all these like 22 patients, there were only two patients who had exacerbations. Out of this prospective study, three out of 343 patients, there were only three patients who had exacerbation. And then there was like two patients who developed new onset, and one patient in this study was it's a case report. This one they reported a patient getting MG after developing MG after vaccination. So it's a small percentage that you may see an exacerbation with vaccination, but there is more exacerbation with the infection itself. So I have to remember that. So though MG is rare disease, the high morbidity and mortality in the context of COVID-19 infection demands like increased awareness of best practices is what their conclusion was. And the rare occurrence of adverse effects of COVID-19 vaccine should not discourage patients, and more importantly, not restrain neurologists from advising this vaccination. So why do some people develop this autoimmune? Why do some people develop the worsening with vaccination, or why do some people develop like new onset like autoimmune disease? Because what they think is there was one this paper they discussed a little more details about this. So vaccines, sometimes when you give this vaccine, they what we call as molecular mimicry, like the immune response would cross react with the antigens that we have in our body. That is, our normal self, normal body. They cross react with the self antigens, and if the vaccination is given, and so they're not able to recognize that this is foreign or a self, and that's how they develop the autoimmune condition. So who develops this and who do not, it's hard to predict that. But there was also a bystander effect is what some investigators have suggested, like there is a inflammatory signals can activate self-reactive T cells, and that can like an immune response, and these can cause immune response to vaccine antigens. And then there is like self tissue damage during an inflammatory cascade, the epitope spreading mechanism. So there's been a few different mechanisms that have been proposed to say that why some people develop like an autoimmune process, or why some people develop a reaction, or an adverse event to this vaccinations. And this was one study from again from don't remember from where, but Taibbi basically et al, like they looked at multiple again, this was from different countries. They looked at, it's a systematic review looking at articles that reported this, and they were trying to figure out can we come up with like who gets this the vaccination, MG worsening after vaccination, or MG onset after vaccination. So in UK, there were 7 cases, Italy, 4 cases, USA. So you can see across, they had a few case cases that reported having MG, new onset MG after vaccination, after COVID-19 vaccination. And they came up with this. They said like it was more common in males and adults over 50 years. And usually if it occurs within the first 2 weeks after vaccination. And the symptoms are not any different from people who develop MG unrelated to vaccination, and most patients are expected to experience partial or complete recovery within 1 month. So you can see that they have they recover with that with the treatments. And the risk of autoimmune diseases with COVID vaccination, this is not just MG, just looking at overall autoimmune diseases during with COVID-19, COVID-19 infection and COVID-19 vaccination. This was a population-based study from Hong Kong, and they looked at I don't know if you can see this very well, but this was, they looked at the incidence of autoimmune diseases. Again, myasthenia was not one of the diseases that they looked at here, but this was like over 1 million patients with COVID-19 infections, and then people with non-COVID infection. And they looked at how many of them developed, autoimmune diseases or had new onset of autoimmune diseases. This is just with COVID infection. I'm not talking about the vaccination. We are talking about just the infection. And this graph shows that with the infection itself, there were more number of people having, the dark blue is the one people who had COVID infection, and the light blue is people who did not have COVID infections. And you can see and these are various autoimmune diseases, and you can see the number of autoimmune diseases over a period was more in 10,000 per person years was more for patients who had COVID infection versus who did not have COVID infection. And similarly, this is also median follow-up, looking at the dark is non-COVID and the red is non-COVID, the blue is COVID. Median time to follow up and first and third quartile. This is with the vaccination, they have noticed less infection, less autoimmune diseases. Actually, they didn't see much of difference. Among COVID-19, completion of 2 doses of COVID vaccination showed decreased risk of some of these autoimmune conditions. So based on this, their conclusion was that COVID-19 infection may be associated with an increased risk of developing various autoimmune diseases. Risk could be attenuated by COVID-19 vaccination. So with vaccination, you can decrease that. Further studies investigating pathology and mechanism would be valuable to interpreting our findings. However, I have to say this did not include myasthenia gravis. It is other autoimmune conditions. There are a few neurological autoimmune conditions also included in this study. It's not just, other autoimmune conditions, but even neurological, but not MG. MG was not part of it. So now we talked about COVID vaccinations, and we talked about influenza and other vaccinations in MG patients. But now what about like immunotherapy? Like, all our, most of us on having MG like are on immunotherapy. So what is the evidence, or what about immunotherapy and vaccinations? So vaccinations are essential part of management for neuroimmunologic diseases. Most of the conditions should be, and the recommendations are like according to this paper, and according to the studies here, they said like it should be administered before initiation of immunotherapy would be great. Appropriate intervals between vaccinations and treatment may vary with the treatment and vaccination, and we'll talk a little more about that. Inactivated vaccines are usually considered safe in neuroimmunologic diseases, but live vaccines, you have to be careful when you're giving them, and especially if you're on immunomodulatory therapies like steroids, or if you're on rituximab, or, usually you prefer, we don't want to give live vaccines. Inactivated vaccines can still be given. Vaccination responses during immunotherapy can be diminished or abrogated depending on the treatment and the vaccination. antibody titer testing to monitor responses can be considered when appropriate. Like, some of them, I mean, even during COVID, we try to look at the antibody titer testing. But, again, the vaccination titer also we try to test. But again, it's not the only thing that we can, we can say that would correlate with the response. So it's hard to do that. And vaccination must be avoided during the relapses or exacerbations. When someone is having a severe MG exacerbation, we don't want to give a vaccination at that time. We want to wait until they get better from that and before you give that. And then vaccination against COVID infection is recommended for patients with neuroimmunologic disease, but some immunotherapies limit the immune response. So the timing is important. When do you give? So there's always that question about when do I take the vaccination? I'm on steroids, I'm on rituximab, I'm on efgartigimod, the FC receptor blockers. When do I get the vaccination is always a question we get. And optimal timing, again, this is some of it is our own opinion, I would say. And we don't have a whole lot of studies to look at this. But for IVIG, the concern for lessened immune response is much lower. And vaccine, usually we recommend like 2 weeks after or 2 weeks before the next infusion. That is, if you're on a 4-week cycle, if you're getting a maintenance every 4 weeks, then we recommend like in the middle of that. And midpoint would be the best. And get COVID vaccination anytime, it's better than not getting it. And for rituximab, the goal is after 2 shots to have 4 weeks. I mean, so you get rituximab, you get 2 injections like 2 weeks apart, and then it takes about 4 weeks to develop immunity. And if rituximab is like every 6 months you're getting it, we would recommend doing it like about 3 to 4, between cycles at about 3 to 4 months and before the next rituximab, if possible. And if eculizumab and plasma exchange, again, may go to midpoint if between the treatments. What about the FCA receptor blockers like the efgartigimod? If you think about the mechanism, it decreases your IgG levels. However, if you look at it, it's working on cell processing of the IgG. It's not inhibiting the production of the IgG, like the immune antibodies when you give the vaccination. So it's actually okay to give, but we would prefer that it's given in between your cycles, of your before your next infusion, or in between, like you have 4 weeks on, 4 weeks off, or 6 weeks on, 6 weeks off, depending on which medication you're using, and either efgartigimod or Rosie, and you do it in between. And so, I mean, Guptill in 2022, they have looked at it, and they said that did not hamper generation of IgG response, but did transiently reduce IgG titers of all specificity. Like they looked at patients with MG, with patient and normal people, and basically they said like it doesn't, these may decrease the IgG levels, but you still have enough immune response, so it to help with the infections. And for MG oral therapies, you can based again, it depends on which immune therapy you're on. Again, cell steps again suppress the WBC more and may cause some issues with that. However, we recommend that, some protection is better than no protection at all. I think that's all I have here, and I am ready for any questions people have here. And I already see, I see some questions here. Any data on exacerbations versus Shingrix vaccination? Herpes zoster vaccination, my MG was triggered by Shingrix vaccination. Again, I don't have any specific data. I have to look at the literature, but I didn't look specifically for that in MG, and it hasn't been reported, at least in the recent literature that I presented. I didn't see that, So again, saying that the data that I showed, there are with different vaccinations, there's 1 or 2 patients that had a triggered new MG or MG exacerbation. So there are some people that have exacerbation, again, if you look at the overall data, it's still considered safe based on, the infections causing exacerbations and, and in general population, the MG incidence based on that, we still consider the infection. So again, in individual person, if that vaccination caused an adverse event to you, maybe avoiding that in future, that's one thing. And the other thing is, again, previously the herpes zoster vaccination was live vaccination, which we would recommend not taking it, but now it is inactivated, and so we are okay with that, with our patients with on immunosuppressive therapies. So I hope I answered that question. The next question I see here, Alison, do you want me to just go ahead and look at that, or do you want to drive that? I didn't know.
That's okay. If you want to go ahead and tackle them, that sounds good.
Yeah, I see that the second question I have, my MG symptoms started with an hours of getting a hepatitis B and flu vaccine in 2001. I had an anaphylactic reaction to the J&J vaccination. I have learned it was the polysorbate 18 vaccine that I'm allergic to. So that is a really interesting point that you brought up, Dawn. So it's not always the vaccine itself. So the vaccine is packaged in, again, different substances, I would say, like in different vaccinations. So people may be allergic to the components of what that has. It may not even be the actual constituent. So that is a really good thing that you brought up. So it's good to know that, this is what caused your allergic reaction. So, next time when you take the vaccination, or if you're thinking of another vaccination, I mean, making sure that it doesn't have this product in there. So I think that's an important thing you brought up. We see, and especially if it happened right after the vaccination was given, it's some kind of an allergic reaction more than, that triggering an immune response. Usually it is an allergic reaction rather than immune response. So that is a really good point that you brought up. And I think Al said, like, thank you. That's good. And do you have any idea of what the last Moderna COVID booster I had really made me feel bad for just a week? All of the Moderna COVID shots and boosters for COVID had really no side effects. Um, that is a good question. I think, again, I don't know if I have the definite answer to that. Again, people may react different to different vaccinations, and also to the same vaccination. I mean, I have to say, even my own colleagues had different reactions to, different, I would say, like different duration of symptoms. I would say, like, some had, with the first time they took the COVID vaccination, they did not have like fever or pain, but the second time they took, they had more pain, or the vice versa, they had more pain when they took first time. Or so I think it can be varied response. So again, I'm not sure why specifically you had that, but again, immune response can be different in different, with the same vaccination different times. Again, it's your body, how it reacts to that vaccination. I think that's all I see there. I don't know if you have any more.
It looks like, did you see the Q&As?
I didn't see the Q&A. I'm sorry. I just looked at this one. Sorry. Let me look at the Q&A here. What does seroprotection mean? Seroprotection, we are talking about, the antibodies and, that develop, from, say, you're giving a part of the of a infectious agent, or if you're giving a antigen, what happens? Our body develops antibodies against that. So next time when an antigen gets in, like when an infectious agent like a bacteria gets into your body, now you have seroprotection. You have antibodies that are attacking that. That's what we mean by seroprotection. So my MG was triggered by COVID vaccination. Should I have boosters? So when we say that your MG was, so the important thing to remember is, when did the MG, I mean, if you're talking about triggering, are you talking about like new, like did it just start off after MG, after vaccination, if it happened after a vaccination, so when in the course of vaccination did it happen? Like we talked about, like, did it happen like within the first 2 weeks, because like we saw the study, the first 2 to 6 weeks is what we say, anything that is related to the vaccination, we say up to 6 weeks, we say it's maybe related to the vaccination. Again, if it happens within the first few hours, it's probably an allergic reaction. You probably don't need to, you shouldn't be taking that again, like at the end. But if it's not, if it occurred like months after that, it may not be related to the COVID vaccination, and it may be just that, in a general population, we know that there's increased awareness of MG now, and there is increasing diagnosis of MG. So it could just be that you're developing MG. So it's hard to say, but if it's occurring within the first 6 weeks, you may have to be careful about like taking the same vaccination. But the other vaccinations are fine. You don't, because even with GBS, that's one of the autoimmune condition in neurology that we see after vaccination. Even that, we always say it's specific to that vaccination. So if someone had GBS after flu, that doesn't mean a flu vaccination. It doesn't mean that you shouldn't take any vaccination. You can take the other vaccinations. I mean, it's only that the vaccination that caused your, that triggered that you shouldn't be taking that. So when talking of COVID vaccines, are you making a distinction between original vaccines and later so-called booster shots? I did well with the original COVID vaccines, but went into extreme exacerbation after the second booster shot, which lasted 8 months. Again, when I was talking about COVID vaccinations, I'm not specifically distinguishing between the various vaccinations. Again, there are some data showing the differences between one COVID vaccination versus other, but we don't have a whole lot. I mean, from what I read on them, the most of the patients had with AstraZeneca, like some of the other vaccinations, with Pfizer mRNA vaccinations, people that developed like after the second booster, they may have developed like the exacerbations, but with the if they develop vaccine, not everyone develops that, but if they develop, they have developed after the second. But with the other vaccination, they have developed within the, like AstraZeneca, after the first vaccination. So again, there's some data on that, but there's not a huge data on that. Again, like I said, there are various reasons that people have exacerbations. Again, I mean, if it wasn't the same vaccination, maybe thinking about it, look at it and see, was it a different vaccination you got, or, is that what caused some of your symptoms, So again, I don't know if I gave you the right, the full answer to your question, but again, I mean, there's not a huge amount of data between the various vaccination and MG exacerbations. And then clarifying, did you say general rule, if vaccination caused you a problem, avoid it in future? So no, I wouldn't say it's a general rule. And what I'm saying is, if you had, say, for example, influenza vaccination, and you had a autoimmune condition within the first 2 weeks of that vaccination, and you think that that might be related to it, and your doctors think that that is related to it, then maybe not getting that vaccination, but you can get the other vaccination. So it's not a general rule that you cannot get any vaccination. And let's see.
I think those were all the questions and Q&A that we had. Is there anybody else that has a question? All right. Dr. Pasnoor, that was fantastic, very informative. I don't think that we have any other questions or comments. So with that, we'll close it up for this morning. Thank you again for joining us. Yes, we are recording this morning's webinar, so it'll be up on YouTube sometime next week. We'll let everybody know when that is. So thank you again for joining us, Dr. Pasnoor. Thank you for taking your time out this morning to share this information. Everybody have a great weekend. Thank you.
Yeah, thank you all, and for joining in, and thank you, Allison, for this opportunity to present.
Great. Goodbye.